This is a sketch showing different types of systemic collaterals to the lung. Again, one would be the normal intercostal bronchial collaterals or bronchial arteries that connect with the pulmonary arteries at the precapital level. Secondly, there may be systemic arteries that arise directly from the aorta that go into the lungs and are not necessarily distributed as a bronchial artery. And finally, we have the extrapulmonary anastomosis from arteries in the chest wall that connect with the pulmonary arteries. If there is a bridging of the gap between the two layers of the pleura, following pleural effusion, adhesions, and in the presence of ischemia in the lung, the adhesions will allow vessels to go from the chest wall into the lung. If a patient is born without a pulmonary artery and there is no ductus arteriosus, how can blood go into the lung? This is a cast corrosion preparation, the ventral projection of a patient who had atresia of the pulmonary trunk and of the left pulmonary artery. Note that the patient has a right-sided aortic arch, and note that the right lung is larger than the left. There is a very large plexus of arteries in the subcarinal region. This means that systemic arteries that arise from the proximal descending aorta penetrated through the hilus, the left lung, and connected with patent arteries within the lung. Remember that there is a triple embryologic origin of the pulmonary circulation. The pulmonary trunk is the result of the septation of the truncus arteriosus. The right and left primary divisions of the pulmonary trunk, so-called right and left pulmonary arteries, are the result of the development of the arteries from the right and left sixth aortic arch. And the intrapulmonary arteries are the result of the proliferation of arteries in the lung buds. In this case, the patency of the intrapulmonary arteries allowed the connection of systemic arteries directly into the lung. This patient had a pseudotruncus arteriosus. There was a nubbin of the pulmonary artery origin. The patient also had a right-sided aortic arch. Note that in the aortographic phase of the injection, we can see abundant systemic arteries that arise from the proximal descending aorta and enter the lung. So this is an in vivo demonstration of bronchial arterial supply to the lung with expansion of the bronchial circulation from a congenital condition that deprives the lung from pulmonary arterial blood flow. There are four types of persistent truncus arteriosus. In the first three, we may see some degree of vascular plethora, and the pulmonary trunk arises as a separate vessel from the dorsal aspect of the trunk, or it can be replaced by a right and a left pulmonary artery, which may share a common orifice, or each arise independently from the truncus. In other words, in all these three modalities, there is increased pulmonary blood flow coming from the truncus directly into the lungs. However, there is a type 4 where there are no pulmonary arteries. And one way that the lungs become supplied is by an expansion of the systemic vessels which arise from the proximal descending aorta, which are the bronchial arteries. In this case, we see to the left a frontal view of a patient with a persistent truncus arteriosus. Note the prominence of the left ventricular contour, and note the oligemic lungs with a feathery pattern that represents collateral circulation. To your right, a poor angiogram which shows opacification of the vessels in the lung following an injection in the aorta. There was no ductus arteriosus present. The vessels that we see are the opacified systemic arteries that arise from the proximal descending aorta. This is a lateral image of the patient with a persistent truncus arteriosus. Note that there are vessels that branch as if they were small pulmonary arteries. They actually represent enlarged bronchial arteries. And note that there is a large bronchial artery coming off the proximal descending aorta, as indicated with the white arrow. An interesting finding is the lack of an oval density that should represent the right pulmonary artery seen on end, which normally projects in front of the trachea in the lateral view of the chest. This is because this patient did not have right and left pulmonary arteries. There is also a very unusually clear aortic pulmonary window due to the absence of a left pulmonary. This is a patient who had an infarct of the lung where we can see proliferation of bronchial arteries. And note that they're not markedly increased nor markedly dilated. This is to show that ischemic conditions that result from a pulmonary thromboembolism may lead to increase in the number and size of the bronchial arteries, but they never get to be as large as we see them with congenital conditions of absence of pulmonary arterial flow and in inflammatory processes where the bronchial arteries markedly expand. This is a very rare case of a mass in the left upper lung field, which showed some spiculated margins, and it was initially considered to represent a fungus ball or some sort of a neoplasm. We can see in the bronchial arteriogram in the bottom left increase in the size and number of the bronchial arteries. This favored the diagnosis of an inflammatory process. At surgery, a cavity was removed, filled with epidermis. This turned out to be an intrapulmonary teratoma, and the blood supply to this teratoma was primarily from the bronchial arteries. Note that there are yellow hairs in the surface of the mass, and it has been stated that if a patient expectorate blonde hair, think in intrapulmonary teratoma. This is a patient who had Landing-Cherky disease or fatal granulomatosis of childhood. Note the consolidation of the right upper lobe. Note in the third picture that when the aorta opacifies, we see tremendously enlarged numerous bronchial arteries supplying the right upper lobe. In the presence of active inflammatory disease, and particularly suppuration, and these individuals have granulomatosis with considerable inflammatory cells and hypervascularity, the blood supply to this area is due to the bronchial arteries and not to the pulmonary artery. The pulmonary artery may be present or often it is occluded, and the lesion is supplied by the systemic arteries, in this case the bronchial arteries. In this close-up of an aortogram of the same case, note the tremendously enlarged, abundant bronchial collateral circulation or bronchial arteries that supply the right upper lobe. This patient had fibrocystic disease. Note that there is consolidation in the right upper lobe and a very large bronchial arterial plexus, which represents the systemic supply to inflammatory regions of the lung. Any type of suppuration, bronchiectasis, pneumonias, granulomatosis can elicit increased bronchial collateral. This is a patient who had cavitary changes in the right lung due to a pulmonary abscess. Note in the wall of the abscess increase in the bronchial arterial. This is an avascular pulmonary nodule which proved to be a hamartoma. Note that there is no vascularity in this nodule. Whenever we do a bronchial angiogram and we find that there are no vessels supplying the lesion, we have to assume that we are dealing with either a healed granuloma or a hamartoma. This was a hamartoma. This is a patient with a large nodule which had a central calcification, and medial to it there was a non-calcified smaller nodule. We expected a calcified granuloma, in this case proved to be a histoplasmoma, or the other possibility was a hamartochondroma of the lung. By bronchial arteriography, and particularly because this nodule was calcified in the center, it was predicted that the bronchial angiogram would show avascularity. To our great surprise, there was a neovascularity within and around the nodule. The nodule was then removed, and it still was a histoplasmoma. But there were active inflammatory changes around the calcified area, which means, therefore, that if a nodule has activity, it can show neovascularity that will be indistinguishable from the neovascularity of a primary metastatic tumor to the lung. In other words, it is not possible by bronchial arteriography to be absolutely certain of the histological nature of a vascularized pulmonary nodule. On the other hand, if the nodule is avascular, this suggests that it is either a non-active granuloma or a hamartoma. This is a patient with a pneumonitis of the right base, and note the minimal increase in the arterial supply to this area. In other words, there is a minimal bronchial hypervascular. This is a patient with upper lobe tuberculosis. Note that the stranding between the left upper lobe and the left hilus is partially due to bronchial arteries. The bronchial arterial hypervascularity is the result of the inflammation of the upper lobes. When we see stranding from a lung lesion towards the hilus, some of the tubular or linear densities are the bronchial arteries supplying the process. We may see linear densities due to atelectasis, to fibrosis, to increase size of the bronchial arteries. All these constitute the differential diagnosis of linear densities. Occasionally tumor around the pulmonary artery and in the connective tissue around the bronchi, the so-called axial connective tissue, can also lead to stranding between a lesion and the heart. This is a patient with a bronchial adenoma. To your left is a bronchogram that shows a filling defect in the left main bronchus. To your right, the upper image is the endoscopic appearance of the bronchial adenoma, and the lower image is a cast corrosion preparation that shows abundant bronchial arteries that supply the lesion. The most hypervascular tumor that we have seen is the bronchial adenomas, and we know that the biopsy of these lesions can be hazardous because of active bleeding, and the bleeding comes from the hypervascularity that results in a large area of vessels within the lesion and around the lesion, which represent the bronchial arteries. Because they have blood at systemic pressure, a large biopsy of a lesion can produce tremendous bleeding. This is a patient with a carcinoma of the right lower lobe. Note an area of bullous emphysema in the left side of the slide, and the dark gray vessels represent increased bronchial arteries supplying the tumor. Primary and secondary malignancies of the lung are supplied by the bronchial arteries. This is a case with a carcinoma of the right upper lobe, and note that there are dark vessels that represent the hypervascularity of a squamous cell carcinoma that was partially. A close-up of the cancer shows the cavitary lesion in white and the neovascularity at the expense of the bronchial arteries in a dark blue vessel, the neovascularity of a squamous cell carcinoma of the lung. A solitary pulmonary nodule outlined by the arrows was supplied by bronchial arteries, proved to be a bronchial carcinoma. We believe that if a nodule shows hypervascularity, it's a surgical nodule. It could still be an active granuloma, but it may be a primary or a secondary malignancy of the lung. Peripheral lesions, in this case a carcinoma, can receive a blood supply also from the intercostal arteries. In this left upper lobe carcinoma, the neovascularity came from the left upper bronchial artery as well as from adjacent intercostal. If we have a lesion and we do not see hypervascularity, it may be that we did not inject the vessel supplying the lesion. This is illustrated in these two different bronchial arteries that were injected. The one to your left shows the neovascularity of the tumor. The picture to your right represents another bronchial artery which did not supply the tumor. Mediastinal involvement can be also revealed by bronchial angiography. This is a patient who had a superior vena cava syndrome that you see on your left side, total occlusion of the superior vena cava with retrograde filling of the left innominate vein and the azygos vein. And you can see to your right selective bronchial arteriography, which revealed uniform neovascularity of both a primary tumor in the right upper lobe as well as the mediastinal involvement by the tumor, which is manifested by increased bronchial hypervascularity. If there is a superior vena cava syndrome, it may be useful to inject something like nitrogen mustard into the bronchial artery to necrose and shrink the tumor. Bronchial angiography can help in establishing the prognosis of a cancer. In this patient who had a right upper lobe bronchial carcinoma, there was virtually no blood supply from the pulmonary arteries. In general, pulmonary arteries supply small tumors when they're small and they're in a peripheral location. When the tumor is large, usually the pulmonary artery not only does not supply the lesion but may be obstructed by the lesion. And note to your right the venous face of a pulmonary angiographic examination that shows that there is no vascularity of the lesion. Again, a poorly vascularized neoplasm. A selective bronchial arteriographic study of this neoplasia shows minimal neovascularity in the lower portion of the tumor. We can predict that both irradiation and chemotherapy will be not very effective in view of the almost avascularity of this large necrotic tumor. The mass in the right lung was a metastatic endometrial carcinoma, and the neovascularity that we see in the medial and inferior aspect of the lesion is very typical of a cancer because of the irregularity of the vessels. However, as we have shown before, some active granulomas may show a distorted vascular pattern, and it may be very difficult to make a distinction between an active granuloma and a neoplastic process. This is a case of lymphoma. The half of the slide on the left is a close-up of the right lung, and the other half of the slide to your right represents large masses, and both the right upper lobe as well as the left lung masses were supplied by the bronchial arteries. Bronchial hypervascularity is the result of the actions of growth hormone or any type of parenchymal process, be that inflammatory or neoplastic, in view of the fact that the bronchial artery is the nutritive artery to the lung. It's like the hepatic artery to the liver. And thirdly, ischemic areas of the lung can provoke increase in the size and number of the bronchial arteries. So these are the three mechanisms of increased bronchial hypervascularity: congenitally or acquired ischemic lesions of the lung, inflammatory and neoplastic processes, and experimentally the use of a growth hormone. Selective bronchial arteriography is utilized not so much for diagnosis as for treatment. In patients that have active bleeding, we can embolize the bronchial artery supplying the area of bleeding. This particularly is helpful in patients with bilateral bronchiectasis. Secondarily, the bronchial arteriographic examination can be employed for the treatment of bronchial cancers. If a cancer of the lung is causing pain or superior vena cava syndrome, and the patient does not benefit from irradiation and or chemotherapy, selective bronchial infusion of a chemotherapeutic agent such as Cytoxan or nitrogen mustard can improve the situation. In this particular case, a large tumor was seen in the right upper lobe that was supplied by the bronchial artery. The picture to your right are 4 images. The bottom left and right are after several weeks when infusion of nitrogen mustard was made. Initially, the lesion got larger because of edema, but eventually the lesion got smaller, and the pain this patient had in the right upper hemithorax disappeared from a single injection of 15 milligrams of nitrogen mustard.